we are going to discuss today on drugs used for HIV, human immunodeficiency virus. Anyone about something on the HIV virus? HIV is basically a RNA virus. It contains in its genome single-stranded RNA. The peculiarity of the HIV virus is that it contains reverse transcriptase enzyme that is responsible for the basically helping in the transcription of RNA, genomic RNA to the DNA, so that viral replication can occur. So it's a single-stranded RNA retrovirus which uniquely carries out reverse transcription of the proviral DNA from the viral RNA, and this reverse transcriptase enzyme is one of the major target of the drugs that are used in HIV infection. Now, the HIV virus, they primarily attack the CD4 plus T helper cells. As a result, the CD4 cell lysis occurs, it continuously decreases in quantity in the body, and when it is lower below the critical level, that is 200, less than 200 per cc, then what happens, the cell mediated immunity in the body decreases and the person infected with HIV is prone to opportunistic infection like pneumocystis carinii pneumonia, CMV retinitis and others. Now, and hence this patient gradually succumb to death with this opportunistic infection. Now, then one more important thing, this HIV virus, the RNA of the HIV virus during replication, it integrates with the host DNA. As a result, the drug is impossible to eradicate till now, and hence the HIV can't be cured till now. We are just helping in suppressing the replication of viral RNA. So what is about the antiretroviral drugs? These basically, these drugs are active against the HIV virus. What does they cause? They basically do not cure the disease, but they prolong and improve the quality of life, and they postpone the complications related to the AIDS. What is the difference between HIV infection and AIDS? Difference between HIV infection and acquired immunodeficiency syndrome? Actually, AIDS is caused by HIV virus, but we say to develop AIDS in a patient when the CD4 plus count decreases to a critical level below 200, or the patient with HIV, they contract the opportunistic infection typical with that of HIV infected person. To those patients we say they are suffering from AIDS. Now, the clinical efficacy, we measure the clinical efficacy of antiretroviral drugs, that is the drugs that are used against HIV virus, by measuring HIV RNA level and by measuring CD4 plus count. Over the past 30 years, basically a lot of development has occurred for the treatment of HIV, and many drug targets, drug targets have been developed so that we can decrease the replication of HIV and decrease the reduction in the CD4 plus count. The major targets are two. Number one, reverse transcriptase, and number two, protease. Now, before going to that, we should have a knowledge how the replication of HIV virus occurs. Basically, HIV, they attack the CD4 plus cells. Now, when they bind with the HIV, when the HIV virus bind with the CD4 plus cells, there is CCR5 receptor on the surface of the host cell. Now, they help in the anchorage of the HIV virus over there. As a result, the membrane of the HIV virus they fuse with the cell membrane of the host cell, and the virus basically is taken up by the host cell. Now this HIV virus in the basically in the host cell, now what happens due to the action of reverse transcriptase enzyme, the genomic RNA is transcribed to the DNA, and this DNA basically is translocated within the nucleus, and they integrate with the host DNA by the enzyme integrase. As a result, then after integrating with the host DNA, now the transcription occurs, the proteins are synthesized, and a viral polyprotein is synthesized that is cleaved by the protease enzyme to the viral structural and functional proteins. Now, the major target of the drugs used in HIV are reverse transcriptase enzyme, that is responsible for conversion from viral RNA to the DNA, and the second major target is HIV protease, that is responsible for cleavage of the viral pro-DNA in viral pro-protein into the structural and functional protein of the virus. Now, in addition, certain new targets have been developed that include number one, fusion inhibitor. We said the plasma membrane, the membrane of the HIV virus fuses with the plasma membrane of the host cell, and this phenomena is inhibited by fusion inhibitors, also called entry inhibitors. The drug here is Enfuvirtide, chemokine co-receptor CCR5 inhibitors that help in the anchorage of the virus with the surface of the host cell. And the drug here is Maraviroc, HIV integrase. They basically help in the integration of the viral DNA with the host DNA. Example, Raltegravir. Now, what is the aim of HIV therapy? Only two: is a maximal suppression of the viral replication for the maximal period of time as much as possible, as we are not able to cure the disease. ARV regimen generally consists of triple drug regimen. Okay. Why the triple drug regimen? To decrease the development of resistance, and lifelong therapy is needed. Now, coming to the national programs on HIV, generally National AIDS Control Program was initiated in India in the year 1992, and it occurred in 5 phases. We are currently running in 5th phase: NACP 1, NACP 2, 3, 4 and 5. NACP 1 was started to control the HIV spread, and included basically setting up of NACO, that is National AIDS Control Organization, and blood safety rules. Now, key phases include NACP 1 to NACP 4, focusing on awareness and treatment, and NACP 5, which we are currently in from the year 2021 to 2026, are aiming to end the epidemic. And via this program, basically, we have achieved a 46% drop in new infection and 76% drop in the death rate. NACP 1, setup of NACO and blood safety rules. NACP 2, shifted to state level action and distribution of the free antiretroviral drugs. NACP 3, focused on stopping and reversing of the infection rate. 4, expanded treatment access and helplines. And NACP 5, basically works to eliminate the new transmission completely. Now, coming to the drugs that are used for HIV, very important, nucleoside reverse transcriptase inhibitors. Now, there are 2 groups of drugs which inhibit the reverse transcriptase. These are one, nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. By the nucleoside, basically we mean the nitrogenous base, that is adenosine, guanosine, cytidine and thymidine. Now these are NRTIs are basically structural analog of the nucleosides. And what does it do basically? They are present in the, they enters the host cell, they are phosphorylated, and being the structural analog of the nucleoside, when the transcription occurs from viral RNA to the DNA by the enzyme reverse transcriptase, these are incorporated in the viral DNA, and hence faulty formation of the viral DNA occurs and chain formation stops. Thus, they are inhibiting the reverse transcriptase enzyme. They are comparative inhibitor of reverse transcriptase. These include Zidovudine, diadenosine, Efavirenz, Lamivudine, Abacavir and Tenofovir. Among these drugs, Lamivudine and Tenofovir, they are also active against chronic hepatitis B infection. And Tenofovir is actually not a nucleoside reverse transcriptase inhibitor, it is a nucleotide reverse transcriptase inhibitors. The difference between the nucleoside and the nucleotide is basically one is the phosphorylated form of nucleoside. Coming to the non-nucleoside reverse transcriptase inhibitors, they are not the structural analog of the nucleoside. They also inhibit reverse transcriptase, but the locus of action is different, and they are the non-comparative inhibitor of reverse transcriptase. Two drugs are there, Nevirapine and Efavirenz. The third drug, that is retroviral or protease, simply protease inhibitors, PI. Now they inhibit the protease enzyme. They inhibit the protease enzyme which was responsible for cleavage of the viral protein into the structural and functional proteins of the virus. Now next, the new targets are entry inhibitor or fusion inhibitor, that include Influvatide, CCR5 receptor inhibitor, Maraviroc, and integrase inhibitor, Raltegravir. Now coming to the nucleoside reverse transcriptase inhibitors, today we will discuss the three major groups, NRTI, NNRTI and PI. Now coming to nucleoside reverse transcriptase inhibitors, they include Zidovudine, diadenosine, Efavirenz, Lamivudine, Abacavir and Tenofovir. Now Zidovudine basically it's a thymidine analog, it's azidotymidine. Now it's a prodrug, it is taken up by the body or the host cell, phosphorylated into the Zidovudine triphosphate, and ultimately as discussed earlier, they inhibit the reverse transcriptase enzyme. Zidovudine just thus basically prevent infection of new cell by HIV. What Zidovudine is causing? It is inhibiting reverse transcriptase enzyme. It is reverse transcriptase enzyme basically inhibit the transcription of viral RNA to DNA. So they are effective only in newly infected cell, but not in the old infected cell. Why? Because in old infected cell, the HIV virus DNA has already been integrated into the host DNA, and hence there is no role of reverse transcriptase enzyme. So Zidovudine thus prevent infection of new cells by HIV, but has no effect on the proviral DNA. It is effective only against retrovirus. Resistance to Zidovudine develops by point mutation. It was used previously as monotherapy, and it was very effective in decreasing the HIV RNA assay and improving the CD4 plus count, but with the continued use of the drug, resistance quickly developed by the point mutation. So we do not use monotherapy in treating HIV patient, we use triple drug regimen. These are all about the pharmacokinetics. Now adverse effect. The most important, basically important adverse effect with Zidovudine is bone marrow suppression leading to anemia and neutropenia. It develops because of the partial inhibition of cellular mitochondrial DNA polymerase gamma, which has got higher affinity than chromosomal DNA polymerase. Anemia and neutropenia are the most important and dose-related adverse effect. Nausea, anorexia, abdominal pain, headache, insomnia, myalgia are common at the start of the therapy, but with continued use they decrease. Myopathy, pigmentation of nails, lactic acidosis, hepatomegaly, convulsion and encephalopathy are infrequent. Coming to interaction, now in the pharmacokinetic, the important one is zidovudine is metabolized by glucuronide conjugation, the same enzyme that is responsible for metabolism of paracetamol. So, paracetamol increases zidovudine toxicity probably by competing for glucuronidation. Again, azole antifungals, they inhibit the CYP3A4 enzyme. They also inhibit zidovudine metabolism. Other nephrotoxic, myelosuppressive drugs, probenecid, they enhance toxicity. And important one, stavudine should never be combined with zidovudine. Why? Because both are thymidine analog. They compete the same pathway and one decreases the efficacy of the other. Uses, they are used to treat HIV patient. Generally triple drug regimen is used, of which zidovudine is one of the two optional NRTI used by the NACO, that is National AIDS Control Organization. Number 2, they can be used for post-exposure prophylaxis of HIV. Number 3, they can be used to prevent vertical transmission from the mother to the offspring. Zidovudine common complication কি আছে বলো important complication zidovudine reverse transcriptase inhibitor এর নাম বলো কিছু reverse transcriptase কি করে হ্যাঁ ইনহিবিট করে ডিএনএ করে তো হ্যাঁ হ্যাঁ ড্রাগ তো নাম কিছু বলতে পারবি ল্যামিভিউডিন আর কিছু এখন যে ডিসকাস করলাম আমরা জিডোভিউডিন ওকে আচ্ছা বল আমাকে নিউক্লিওটাইড রিভার্স ট্রান্সক্রিপ্টেজ ইনহিবিটরস কিছু নাম বলতে পারবি হ্যাঁ 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 ও এনআরটি ওটা এনআরটিআই অনলি NNRTI huh Nevirapine good. So coming to the zidovudine, basically it's a nucleoside reverse transcriptase inhibitor. It's a thymidine analog. It basically the drug basically it converted into the host cell in the active form zidovudine triphosphate that is responsible for the inhibition of reverse transcriptase enzyme. It is metabolized by glucuronidation. As a result, paracetamol when co-administered with the drug, it increases the toxicity of the drug. The important complication with zidovudine is bone marrow suppression, that is anemia and thrombocytopenia. And the drug should never be combined with stavudine because both have the same pathway for reverse transcriptase inhibition, and they compete with each other, decreasing the efficacy of each other. Coming to the diadenosine, is basically a purine nucleoside analog. It's a structural analog of adenosine. It competes with ATP in the host cell. After phosphorylation to diadenosine triphosphate, it competes with the ATP and thus inhibits the reverse transcriptase enzyme. It is equivalent to zidovudine in efficacy, and but the use has been declined because of toxicity. The important toxicity with diadenosine is peripheral neuropathy, that is the gloves and stocking pattern neuropathy, which may be irreversible, and hence it is no longer used nowadays. rarely may cause acute pancreatitis, diarrhea, abdominal pain may develop. Coming to the stavudine, like that of zidovudine, is a thymidine analog, and it competes with the basically it does inhibit the reverse transcriptase enzyme, efficacy similar to that of the zidovudine. Now it should not be combined with diadenosine. Why? The complication of the two drugs are same, peripheral neuropathy, and that may add up. Resistance to stavudine develops as for other NRTI. The efficacy is comparable to zidovudine. The complications, particularly important one is peripheral neuropathy, others are lipodystrophy, lactic acidosis, and rarely pancreatitis. Lamivudine is basically deoxycytidine analog, and it inhibits reverse transcriptase, and it also inhibits basically HBV, hepatitis B virus DNA polymerase enzyme. So it is not only used in HIV infected patient, but it is also used in chronic hepatitis B virus infection. Now, resistance by point mutation, some cross resistance with diadenosine can develop. It may be used in combination therapy as the first line regimen for the treatment of HIV. Now, they are also useful in chronic hepatitis B infection, and they effectively reduces the HBV DNA titer level and improve the biochemical and the histological indices of liver function. They are generally well tolerated, toxicity is low, side effects are few: headache, fatigue, rashes, and others. Hematological toxicity does not develop like that of zidovudine. Coming to the Abacavir, it is a guanosine analog and thus inhibit the reverse transcriptase enzyme. Resistance slow to develop and little cross resistance with other NRTI. The important complication with the use of NRTI with the use of Abacavir is hypersensitivity reaction that include basically fever, rashes, abdominal pain, bowel upset, and flu-like respiratory and constitutional symptom. That is seen in 2 to 5% of the treated individual. Possible basis is genetic, and the cause is a massive surge in the TNF alpha level. Now, if the patient develop hypersensitivity reaction to the drug Abacavir, the drug should be stopped immediately. Why? Because it has been seen when the drug is continued further, then fatality may occur. So the drug should be stopped immediately, and in fact Abacavir should never be given again to a patient who has developed hypersensitivity reaction. Other side effects are not serious. Tenofovir. Tenofovir is again one of the NRTI that is helpful in the hepatitis B virus infection. So it is the only nucleotide, not nucleoside analog. It is relatively a newer addition. It is also effective against hepatitis B virus. Previously it was used to treat only the previously treated patient. Now they are included as the first line regimen event. Coming to the non-nucleoside reverse transcriptase inhibitors. So what are nucleoside reverse transcriptase inhibitors? Enumerate them. Enumerate nucleoside reverse transcriptase inhibitors. নামগুলো বলো। zidovudine, good. Lamivudine. আর sorry, Abacavir. আর Tenofovir. কোন ড্রাগটা ক্রনিক হেপাটাইটিস বি ইনফেকশনে ইউজ করা যাবে? তা জিজ্ঞাসা করলাম, কোন ড্রাগটা ইউজ করা যাবে? The drugs the NRTIs that can be used in chronic hepatitis B infection. দুটো ড্রাগ আছে, Lamivudine, Tenofovir. As a complication with the most important side effect of Abacavir, এখনই পড়লাম আমরা Abacavir important complication. পিছনে Most important complication of Abacavir? Important complication of Zidovudine? Anyone here? Huh? Bone marrow suppression. Diadenosine? Huh? Nah. Peripheral neuropathy. আর কোন ড্রাগটা পেরিফেরাল নিউরোপ্যাথি করে? ইম্পর্টেন্ট, হ্যাঁ? ডাইডানোসিন ছাড়া স্ট্যাবিউডিন। ওকে, অ্যাবাকাভির ইম্পর্টেন্ট সাইড এফেক্ট কি আছে, কি বলবে? অ্যাবাকাভির ইম্পর্টেন্ট সাইড এফেক্ট হাইপার সেনসিটিভ রিঅ্যাকশনস। যদি ডেভেলপ করে সঙ্গে সঙ্গে ড্রাগটাকে স্টপ করে দিতে হবে, না হলে কিন্তু ডেথ হওয়ার সম্ভাবনা বেশি। Now coming to the next group of drug, non-nucleoside reverse transcriptase inhibitor. Now these are not the structural analog of nucleoside. They act at a different locus in the reverse transcriptase enzyme, and they are non-competitive inhibitor of reverse transcriptase. Now these drugs are more potent on HIV-1 compared to Zidovudine, but they have got no effect on the HIV-2 virus. So the patient infected with HIV-1 virus can only be treated with NNRTI, not with HIV-2. Again, resistance developed by point mutation, they should always be combined, as said earlier, with two other important anti-HIV drugs, because we prefer triple drug regimen, so that resistance is slow to develop. Now the cross resistance with NVP. Now there are two drugs are included here, Nevirapine and Efavirenz. Cross resistance between the Nevirapine and Efavirenz is seen, so they should not be used together. Sorry, as the cross resistance is seen, a person who has developed resistance to Nevirapine should not be given Efavirenz or vice versa. Now the important in the pharmacokinetic is that they are enzyme inducers and they cause auto-induction. Auto-induction mane? What do you mean by auto-induction? They induce their own metabolism. Any example? Leaving them. Any example? Carbamazepine. They show auto-induction. So basically they are enzyme inducers and they show an auto-induction of their own metabolism. Efavirenz also inhibits CYP3A4, cytochrome P3A4. Now Nevirapine, as they show auto-induction, Nevirapine is started at the dose of 200 mg per day, and after 2 weeks the dose is doubled as the blood level goes down by auto-induction. But this effect is not so much with Efavirenz, and his dose is not escalated with Efavirenz. Now if a patient being treated with the second important one is rifampicin. Rifampicin, they induce the Nevirapine metabolism, okay, and thus decreases the efficacy. So a patient of HIV on Nevirapine, if they contract TB, tuberculosis, the Nevirapine should be withdrawn and it should be replaced by Efavirenz, because Efavirenz metabolism is not induced by rifampicin. The NNRTIs are indicated in combination regimens for HIV. Now coming to adverse effect, the important adverse effect with Nevirapine are rashes. So rashes are the commonest adverse effect, followed by nausea and headache. Occasionally skin reactions are severe. Fever and rise in transaminase may be seen, and basically Nevirapine should not be given in a patient with hepatic dysfunction. Hepatotoxicity is lower with the Efavirenz. So in hepatic dysfunction, basically Efavirenz is preferred. Efavirenz, the side effects are headache, rashes, dizziness, insomnia, and the important one is neuropsychiatric manifestations. And the discontinuation rate is lower as the side effects are milder and decreases with the continued use of the drug. Now, Efavirenz show teratogenicity, and it should not be given to the pregnant mother or the women who want pregnancy. These were all about the NNRTI. Coming to the PI, protease inhibitors. The protease inhibitor mechanism of action key. Mechanism of action of protease inhibitor, inhibit protease enzyme. What does protease enzyme do? Sorry? Protease mean they break down the protein. So inhibitor, they inhibit the breakdown of protein. Which protein? Viral protein that has been synthesized from the host DNA integrated with viral DNA. Okay. So these protease inhibitors, they inhibit the protease enzyme which are responsible for the cleavage of the proviral DNA into the structural and functional viral proteins. The drugs, 6 drugs are there: Atazanavir, Indinavir, Nelfinavir, Sacfinavir, Ritonavir and Lopinavir. Lopinavir is generally marketed in combinations with Ritonavir, and this regimen is called boosted PI regimen, boosted protease inhibitor regimen, that we will discuss later on. Now, because they act at a late step of viral cycle, we discussed previously that NRTI, they basically are effective in the newly infected cell, but these protease inhibitors, they are effective both in the newly infected and chronically infected cells. Why? Because they are basically acting at a later stage of viral replication. Now coming to the metabolism, they are potent inhibitor of the CYP3A4 isoenzyme, very important, and they induce, and some of them induce even CYP other isoenzymes. As they are potent inhibitor of CYP3A4 isoenzymes, they show many drug interactions. So when another drug is co-prescribed with protease inhibitors, always manufacturer's insert should be seen that any drug interaction is there or not. Now, they are one of the drug included in the triple drug therapy. Generally, it is not included as a first line regimen, although they are very effective. Why? Because if they are included, the armamentarium for the second line regimen will not be there. They are included as a reserve drug when the primary regimen fails. Most guidelines, including the NACO, reserve them for the failure cases. PIs inhibit as well as induce specific CYP isoenzymes to different extent. Drug interactions with them are common and often unpredictable. So, manufacturer's package insert should be consulted while co-prescribing any other drug. Now, these protease inhibitors metabolism, they are induced by rifampicin and other enzyme inducers. The second problem, one is they inhibit and induce CYP isoenzymes. So there is a lot of drug interaction. The number 2 problem with the drug is large tablet load. A large amount of tablet is to be taken daily and it is to be continued for months and years. Around 6 to 18 tablets are taken daily. To prevent this, regimen is there called boosted PI regimen, boosted protease inhibitor regimen. Here the drug protease inhibitor, they are combined with the subtherapeutic dose of Ritonavir at 100 mg daily. এমনি Ritonavir use করতে আমরা 600 mg twice daily drugটা use করি আমরা. But in the boosted PI regimen, one protease inhibitor is combined with Ritonavir at subtherapeutic dose 100 mg daily. What does it gives benefit? How it gives benefit? They basically decrease the first pass metabolism of the drug being used. So bioavailability is increased. Number 2, they decrease the metabolism. So that so the drug level in the body increases and hence efficacy is improved. This is the advantage with boosted PI regimen. So, by using the boosted PI regimen, the large tablet load can be decreased so that the compliance with the use of the drug is better. Now, 4 drugs are used. Among the 6 drugs, 4 drugs are used for boosted PI regimen. That include Atazanavir, Indinavir, Lopinavir and Saquinavir. Nelfinavir is not used in the boosted PI regimen. Why? Because Nelfinavir is metabolized by CYP2C19 enzyme, isoenzyme, which is not inhibited by Ritonavir. So, in boosted PI regimen, we do not include Nelfinavir. Now, coming to the most important complications with PI are gastrointestinal intolerance. Others include asthenia, headache, dizziness, limb and facial tingling, numbness and rashes. But the important complications are 3. Number 1 is lipodystrophy, dyslipidemia and insulin resistance. By lipodystrophy we mean abdominal obesity and then buffalo hump and finally wasting of the limbs and face. By dyslipidemia, there is rise in triglyceride and cholesterol level that can be decreased with the use of hypolipidemic drugs, and due to insulin resistance, the diabetes may be exacerbated. Indinavir, they crystallize in urine leading to the urinary calculi. Now, bioavailability and efficacy of Atazanavir is improved by combining with Ritonavir, as said earlier. Dyslipidemia and other metabolic complications are minimal with Atazanavir, but jaundice may be seen due to the inhibition of hepatic glucurolyl transferase. Coming to Indinavir, hyperbilirubinemia may occur. The drug has to be used with excess amount of water, fluid intake, so that urinary calculi does not develop. It is less frequently used now. Coming to Nelfinavir, Nelfinavir is metabolized by CYP2C19, so it is not a part of boosted PI regimen. Clinical efficacy is somewhat lower than other PIs. Ritonavir is basically a potent protease inhibitor, a potent CYP3A4 inhibitor. Drug interactions, nausea, diarrhea, paresthesia, fatigue, lipid abnormalities are all prominent with the drug. The regimen, we generally use 600 mg twice daily as an anti-retroviral therapy, but generally this drug is used in the boosted PI regimen, where other PIs are combined with the subtherapeutic dose of Ritonavir, 100 mg BD. Saquinavir is present in 2 dose formulation, hard gel capsule and soft gel capsule. They differ in the bioavailability and tablet load is large, side effects are frequent. Lopinavir is generally marketed combined with Ritonavir. Diarrhea, abdominal pain, nausea and dyslipidemia are more common. Its dose need to be increased by 1/3 if Nevirapine or Efavirenz are used concurrently. Thank you.